สปีกเกอร์ของเราก็พร้อมแล้วสำหรับนะครับหัวข้อสุดท้ายของเราในวันนี้นะครับ Okay, ladies and gentlemen, so please welcome Mr. Andrew Bastawrous, the co-founder and CEO of Peaks, which and please come up on the stage.
There were two ladies in a village in Kenya who were the best of friends. They lived in neighboring villages and they spent their lives together. But over a period of 10 years, they stopped seeing each other, literally, because both of them had become blind. Their story is not unique because there are 2 of 36 million people in the world who are blind. And the majority of people who are blind from causes that we know how to prevent or cure. 4 in every 5 people on the planet who are currently blind don't need to be. And it's not just the blind individual that's affected, it's their entire community. Here you can see in one of our clinics in the middle of the week, 2 old men holding white sticks with young children next to them who are no longer in school because they're looking after their children. These scenes are very common where somebody who's blind, their entire community is affected by this issue. When you look at where blindness is in the world, it is most prevalent in sub-Saharan Africa and Asia. But if you look at where most eye care providers are, they're predominantly in the Americas and Europe. And so we have this, what we call the inverse care law, this huge gap between those who need eye treatment and those who can provide it. And this issue is compounded even further. Sub-Saharan Africa has the biggest gap between need and provision. But when you look within a country, such as Kenya, to give you a sense of what that means, for every eye doctor that is working in Kenya, we have 100 working in the UK. And of those that are working in Kenya, the majority are based in the capital city. So out of the 86 eye doctors in the country, 43 are in the capital, and as you go to the remote areas, there's up to 1 doctor per 3 to 5 million people. And so for this reason, in 2012, I left my job as an eye surgeon in the UK, and my wife and I moved to Kenya to establish 100 temporary eye clinics. And we were doing a research project through the London School of Hygiene and Tropical Medicine where we wanted to understand why were people going blind, how many were there, and what were the risk factors that we might be able to prevent. To do this, we had to set up temporary eye clinics all across the Rift Valley, often using the village chief's huts, local schools, local churches, and we would go to very remote locations, often very beautiful, but if you look at where this building is, there is actually no road access to it. So where this photo was taken from, we had to carry over $150,000 worth of eye equipment. It took 1.5 hours to carry it all the way down just to set it up in the clinic. And when there were roads, these were very common problems. The access was very difficult, and we were taking state-of-the-art equipment, the kind of things you'd expect in your best hospitals here. However, most of the places that we went didn't have a power supply. So we used to have to run everything through a petrol-powered generator. We would either use the generator or we'd have to use the minibus to invert the battery. And my slide's not working. The slide's frozen. There we go. So out of the 100 clinics that we established, 70 didn't have power. So we used to run everything from a generator. Also, what was common in these places is we'd have gone to places where there has been no road access, no power, and there was also no water supply. And it was in these most difficult to reach places that this would be the common scene. That would arrive and there would be 200 to 300 people waiting to be seen, the majority of whom were blind unnecessarily. They were blind from treatable conditions. And this started to really bother me. Even if I spent my whole life seeing as many people in these queues as possible, the problem was not going to go away. And it was at one of these clinics, one of the places with no roads, no electricity, and no water, where I went to go and use the pit latrine, the bathroom that was there. And as I went to open the door, I heard a phone ringing. And there was a small old man inside with his Nokia phone, and he came out, and I was really surprised, not so much that there was somebody inside the toilet, but that in the middle of nowhere there was good phone signal. And this made me think, in a country where 80% or more people have access to a mobile device, but only 50% have access to clean running water or sanitation services, surely this must be an opportunity to change things. And the world has changed very rapidly in the last few years. M-Pesa is mobile money in Kiswahili. It currently carries 1/3 of Kenya's GDP via text message. And so when other sectors have been transformed in this way, then I thought it's possible for other things to happen. I don't know if any of you are familiar with this picture. This is a 5 megabyte hard drive in 1968. We've moved on a fair way since then. 1 year later, this is the computer that put the first man on the moon in 1969. That computer is 300 times less powerful than the first iPhone that came out in 2007. 2 years ago, an Android device came out that was as powerful as that first iPhone in 2007 that cost only $10. So the world has moved very quickly in a short space of time, and with it has come opportunity. And so with this big issue and big opportunity, we created Peak, a new way of trying to connect those who are not getting eye services with services to make sure their sight's restored. We started by taking each of the pieces of equipment that we were running in our clinics and trying to replace it with a mobile tool. We rebuilt everything from first principles to redesign the way they were tested. In the mobile vision test, we were able to hold the phone, and whichever way the patient points, we swipe the screen without knowing whether they're giving the right or the wrong answer. The algorithm in the phone records if it's the right or wrong answer. If the patient can't see and shakes the head, we shake the phone, it records that they couldn't see. And it automates the response without the examiner having to go and learn all the process of doing a full vision test. We then put this in the hands of non-healthcare workers, so school leavers, community volunteers, and we sent them out into the community to measure people's vision. And we were finding that they were doing very well. Interestingly, we found that if we tapped into every part of the device, we could improve the quality of our results. So smartphones all have lux meters, which are usually there to alter the screen brightness from when you go from inside to outside. But we tapped into that to measure the room brightness every time we did a vision test. And we were able to show that above a certain threshold, the accuracy of the vision test started to go down because of screen reflections. That enabled us to build in warnings to make sure that the quality of the testing was always done accurately. There were other things we tried to do as well, such as using the front-facing camera to make sure we were the right distance from the patient. But ultimately, we found just a piece of string cut to the right length was actually the best solution. So often, high-tech solutions are not the best way to deal with some of the challenges. Some things you can't build into an app. So this is a classic example of a grandmother having her vision tested and her daughter telling her the answers. So community support. As nice as that is, it's not solving the problem that we need. So there has to be a level of training and education that goes into the examiners. So once we had built a test that we thought could work, we did a large validation study. So that meant testing it against the gold standard test, which was 100 times more expensive, and testing people in their homes and then again in the clinics to see if it was repeatable. And what we were able to show in a paper that we published 2 years ago was that it was accurate as the gold standard, and it was quicker, and it was cheaper. The next big challenge was, now we know how we can find people who can't see, we need to determine why they can't see. And to be able to do that, you need to be able to see inside the eye. So this is the retina. The retina contains more information about the human body than anything else. It's a window to the health of a person, not just their eye. On that far side, there's the optic nerve, which is a direct extension of the brain, and these are blood vessels. And you're able to pick up diseases such as diabetes, HIV, malaria, glaucoma. All sorts can be picked up by being able to see inside the eye. The issue is very few people can see inside the eye and interpret it. It's been something that's been limited to the hands of specialists using very specialized equipment, which they have to interpret as they're seeing it. The alternative is a big camera, which give beautiful images, but have all the challenges of requiring electricity to be stationary and a technician to operate it. So we started building and prototyping devices that would be independent of these issues. And we started creating some smartphone-based clip-on devices. Could you play the video, please? So this was a prototype that allowed us to fit it over a Samsung S3. And after multiple iterations, we were able to find that you could put it in front of a patient's eye and get a view on the phone. And here you can see my long-suffering wife, who has had every single prototype I've ever made tested on her, giving us views of the retina that were comparable to the big desktop camera. So then the next challenge was proving that it worked. And so in the hands of school leavers using a smartphone, they examined the same patients that were being seen as part of my larger PhD study. On a desktop camera, all of the images being independently graded at the leading reading center in Europe. And what we showed is that the two were comparable for a fraction of the price. So then we suddenly had lots of interest of people saying they wanted to buy it. However, our challenge at that point is we were a project, we were not an organization, and these were prototypes, medical devices that we couldn't give to people. So because we wanted to lock in the social mission, having proved that it worked, we decided to run a crowdfunding campaign through Indiegogo. So we raised over $200,000 where we asked the public to buy one of these in advance of us making it so that we could guarantee the production pipeline and get it to people without having to give a stake to anyone in this project, knowing that we wanted to serve those who are the least served and therefore the least likely to be able to pay for it. We released the first public version of this in April this year, and it's now being used in 72 countries. But it was never really about the vision test or the adapter to see inside the eye. It was about connecting people to services like that queue of people when I was in the clinic. And whilst I was working there with one of the eye doctors who was suffering this very issue, he was responsible for a population of 3 million people on his own. And he told me that he knew in schools there were children who were unnecessarily visually impaired, but he didn't have the resources to find them and treat them. And the challenge is, when you send a nurse from the hospital to the school and you see a queue of 50 children, in there will be 2 or 3 children that don't see, but also the majority of them do see. So when you're sending a highly trained person, of whom there are very few, they're spending most of their time with the normal children. So it's a poor use of their resource. Given that we'd proven we could put this tool in the hands of non-doctors, we said, well, could teachers do it? And so we started training teachers to do the vision test so that they could find the 2, so that the nurse and the other teams would only see those 2. And when we started testing this in the school, here's an example of a school teacher testing a child's vision. And he was shocked because he was not aware that the child couldn't see. Equally, the children preferred it to other tests because nobody else in the room knew that they were failing the test. Because normally you can see how you're progressing down the chart, and no one likes to fail in front of their peers. And if you're clever as a child, you can cheat the test because you can learn it as you go in, or you can remember it from one eye to the next. However, the automated algorithm in the test here prevents that happening. Even the teacher doesn't know how the child is doing. But then the teachers kept saying, what does this result mean? What does 618 mean? I don't know. Is that good or is it bad? So we felt we needed a visual way to represent that. So we created a simulator based on the score just delivered in that test that showed the teacher the visual world of that child, which meant they instantly understand the visual world that child was in and that something needed doing. But the child and the teacher don't make the decisions about treatment, it's the parents. So we took a mini Bluetooth printer, and everywhere we went, where a child had failed the vision test, it would create a referral photograph which had that same visual information for the child to take home to the parents. At the same time, we would save the details of any child who'd failed the test. And as soon as we press save, it hits our servers and automates a text message to the parents that's personalized. So your child has been seen on this day and needs to go for treatment. So they get the same message through a text message and a photograph. The head teacher also knows about everyone in their school who's been seen and needs to be followed up because they care about their children getting the best education possible. And head teachers are very competitive. So if you look carefully here, you can see a trophy on the head teacher's desk. We used that to start to motivate the head teachers to encourage children who hadn't passed the test to move on. The slideshow's not moving. What we started doing was telling them how the neighboring schools were doing in terms of children going to the hospital. And when we did that, some of them started organizing their own transport to bring 50 or 60 children at once to the hospital. We created a real-time dashboard that allows the program manager to track everything that's happening in real time. So how many people have been screened, how many have been followed up, how many have been treating it, and with what. And also where there are gaps in the system, where is there a problem that we can improve the service. There is also a geospatial representation of this. So here the number of schools that are being visited can be seen. Where they're grey, it means they're planned. Where they're blue, it means that screening has happened. And when they go green, treatment has happened. And you can click on any one to get more detail. We initially ran this as a randomized controlled trial, and we screened 21,000 children. We found 900 with visual impairment, and that was done by 25 teachers in just 9 days. what they showed was it was possible to take this to a much larger audience. After we'd done that first part in Kenya, we have since gone on to scale the program. So it's now reaching 300,000 children in Kenya. Can we move the slide on, please? And we have a team of teachers going from school to school to cover the entire region. From the work in Kenya, the team in Kenya have now trained a team in India, and the team in India are delivering the same program across the Hyderabad region with a plan to scale it further. And then since then, it's also begun in Botswana. And in Botswana, we've just signed an agreement with the government which will allow us to screen and treat every single school child in the country by 2020. That means an entire population of children growing up with the vision that they deserve and the potential that they have with their better vision. It's not just children who are affected by vision problems. So children suffer for a lifetime with vision problems, and particularly in low and middle income countries, they make up the majority of the population. However, the over 50s in low income countries are responsible for over 85% of blindness. So we also need to target that group. So at the same time, we're using the same system that we're doing for schools, but to do a population-level, community-based service. So this is where we go door to door. We use a solar-powered rucksack that is charging a backup battery. And we geolocate every patient that we found who doesn't see. And then we connect them into our system to be able to find and collate patients to be able to bring them and provide a service to them. Here you can see if we search for any patient by any given demographic or detail that we found. So here are people in Nakuru, where I used to live, who are blind from cataract. Each of the red pins represents somebody who's now contactable, treatable, and traceable. We are able to send them personalized SMSs in the same way as the school program, but sending a text message to someone who doesn't see is not an effective way of getting them to come and receive treatment. So we always identify a key informant in each place, someone who connects those people in that community, who receives the message on their behalf and knows to get them together to help us with the logistics of bringing them for care. We do all of it because of those two ladies and people like them. What I didn't tell you at the beginning is that those two ladies, in that moment that we found them, didn't even realize they were sat together. They had been friends for 20 or 30 years, and in that moment was the first moment they were realized that they were sat together. And this is what happened when we removed their eye patches the next morning. Could you play the video, please? Thank you very much.
Okay, thank you so much, Mr. Andrew Bastawrous. Thank you very much.